Good morning. I'd like to welcome everybody to the Netter School of Medicine, and it's kind of a historical day here for us today because this is the very first symposium ever to be held at the School of Medicine, and I can't be more delighted that it's for the XLH community. So today's format, I'm going to just give a quick overview. Panel 1 discussion will be driven by questions and answers. We have pre-populated questions that were obtained from a query put out to the patients, so they were all derived from the patients. As we progress through the questions, I encourage all of you to ask any questions that may come up spontaneously as a result of the current discussion being held. We have one brief program announcement. 2 speakers were unable to make it today, Ingrid Holm and Regina Getz. They send their regrets, but we have a very talented panel for us today, and I'll allow them to just introduce themselves. The second panel will be more of a didactic session where we have speakers from occupational therapy, physical therapy, the physician's assistant program, and the nursing program. All but one of the panelists are homegrown from Quinnipiac University. They're a wonderful group of people. It is the first time in the history of the XLH Day that we have a panel that's unique to the second panel, and that really is to talk about and discuss sort of the day-to-day issues that come along with a chronic disease that's manifested with difficulty with mobility and pain issues. So they're going to talk about quality of life issues as well as the psychosocial impact of people who are dealing with chronic diseases. So before we begin, I just wanted to invite the president of the XLH network to come up, Becky Mock, to say a few words to you all.
Thank you, Carolyn. We would not have this wonderful opportunity to be at the university today without her dedication and commitment to the XLH network and seeing that we are able to provide a setting for us to have such a wonderful opportunity. Thank you. I just want to thank you, patients, fellow XLH folks, for being here today. We need this information. We need to share this information with others like us. I represent 8 people in my family that have XLH. There are people here who have spontaneous cases of XLH. No one in their family has ever had this disorder, and their child has it. That is quite difficult to deal with in trying to seek a diagnosis and treatment and care. I knew I had it from birth. My father had it, my 2 sisters, my 2 children, my 2 grandchildren. It's generational, X-linked, and we suffer in different ways, but we all have the same disorder. It's like a family here. It's like a reunion. I want to thank the students that are here today. You are our future. I want you to catch the passion for science and research and seeking a cure to help people. And I hope that you will choose XLH. We are a rare bone disorder, and we need your help. You can be our heroes. So please consider doing your research and your passion and focus to help folks with XLH. I want to thank our heroes who are here today, because these are the people who know what's going on with us, who are fascinated and dedicated with helping us live through and prosper with our ability to deal with this rare bone disorder. So thank you so much for having us today.
Thank you. So I'd like to open the session by having everybody introduce themselves. We'll start with Dr. Sharkey.
Hi, I'm Melinda Sharkey. I'm a pediatric orthopedist at Yale. I have had the pleasure of working with Dr. Carpenter and his multidisciplinary metabolic bone disease clinic, and that's where I've Met a lot of children and teenagers with XLH. My practice is general pediatric orthopedics, as well as I have a special interest in bone deformity correction. So that segues nicely with the XLH patients I see.
Hi, I'm Tom Carpenter. I'm a pediatric endocrinologist and have had a long-term interest in metabolic bone disease in children, and with a particular focus on rickets, and in even more particular on XLH and its related diseases. And it's been a long time, so I feel like I'm part of the family too.
My name is Margaret Seton, and I'm a rheumatologist, so I take care of arthritis conditions, and my particular expertise has been in my career a focus on metabolic bone disease in the adult. And it's been this intersection beginning to see the needs in the XLH community as they age and trying to understand the consequences to an adult life that brings me into this community. And thank you for having me. It's a privilege.
Hi, good morning. My name is Raghbir Kaur. I'm a pediatric dentist. I work part-time in New York, New Jersey area, and I teach at Mount Sinai Hospital. I became involved with XLH as a part of dental team while working with Dr. Carpenter at Yale New Haven Hospital. So thank you for having me.
And I am Carolyn Macica. I studied the adult morbidities of the disease, namely the enthesopathy, or the bone spurs that form in tendons and ligaments. That's part of the progression of the disease into adulthood. I also have examined the osteoporosis, or the degenerative cartilage disorder in the disease. And more recently, I've been working in and these were done in collaboration with Dr. Carpenter, who I've had the honor of working with. More recently, I've begun studies to look at the impact of pregnancy and lactation on XLH, on the female skeleton in XLH, with my colleague at Yale, Stephen Tomasini. So again, I feel like I'm a big part of this family too. It's a wonderful privilege to have all of you here today, and I welcome everybody. So with that, we'll start the session, and again, I strongly encourage any questions that come up during the session. Please don't feel shy about asking anything. Thank you. We'll start just by reading the questions, and any of the panelists should feel free to chime in if you have something to contribute. So question 1, submitted by a patient: elevated PTH levels in adults. How often should PTH be tested? How high is acceptable, given that we tend to be somewhat high just naturally? What are the treatment options to bring the numbers down when they get above an acceptable level? And when is parathyroid gland removal recommended or not? Any non-prescription treatments for calming an overactive parathyroid that isn't so bad that it needs medical intervention? E.g., are there any particular foods or medication or something else that might have any effect on the parathyroid? It's a pretty big question. Pick and choose.
Oh. Yeah, this is today, tomorrow, the next day, but it's an interesting question, and it underneath this question is what do we know about what the parathyroid levels are doing to the disease? We know that high PTH levels are not good in the usual setting without the physiology of XLH going on. In that setting, it tends to produce, and the main reason for that is in that setting, it tends to produce very high calcium levels. So in the unaffected population, there's a real push to keep PTH levels down because the calcium goes up so high, and that's damaging to the kidney. In XLH, it all of a sudden becomes a lot more complicated, and part of it is that we see the PTH levels go up, but the accompanying calcium levels they can get high, but they tend not to get high like in what we would call primary hyperparathyroidism. But PTH does other things than simply make your serum calcium level get high. it also works on the kidney to make you get rid of more phosphate. So one of the concerns, and one of the reasons we've been interested in this particular thing for years is because you kind of would work against yourself if you're trying to preserve your serum phosphate level and you're all of a sudden getting in a hormonal situation where the PTH level is working against you, making you excrete more phosphate into your urine, sort of amplifying the basic problem that occurs in XLH. So that's one thing. But other things we've been looking at in some of the studies that some of you have participated over the years, and we finally have actually finished some of those studies in terms of getting all the people in and out and getting all the assays run. And over the summer, our biostatistician has been doing a lot of work with these things, and we're in one preliminary analysis, we found that the PTH levels, the higher the PTH level, the worse your bone scan score is. If you remember how some of you that participated in some of these studies, you had to go get an injection, and then you had to sit under this camera for a while for the scan to occur. And the severity of that scan was then graded by a nuclear medicine guy. And all that data's been in, and these have to be confirmed, but the first pass on it looks like there's some association there. The second part of it is that it is true that the higher the PTH levels, the lower the phosphate. We kind of did this not by taking a single PTH level the way you would in clinic, but if you remember, you had to get your blood drawn every 4 hours, so we could create an area under the curve of PTH, which is a kind of an indicator of how much PTH around the clock your body's being exposed to, and that correlates well with the urinary, well, with a serum phosphate load also in an area under the curve pattern. So one of the concerns is, although FGF23 we know is central to this disease, PTH working together with FGF23 may actually mediate some of the disease. So what I'm trying to get to is that there may be reasons to treat PTH here even though your serum calcium level hasn't gotten high, because it may help other features of the disease. Perhaps the bone disease if those initial observations hold up, but certainly preserving your serum phosphorus level, which we know is also part of what we have to deal with. So with that kind of background, how do you translate that to what to do clinically? And I think various places have given their experience, have evolved to certain ways of doing this. Certainly in the children I see, I like to make sure there's a PTH level at least every 6 months in the chart. Sometimes I even do them more frequently. And usually in the children, we're not dealing with situations that have evolved to a really high, irrepressible parathyroid hormone level, which can happen though. It's rare in children, but it can happen, but that tends to be more of an issue in adults that have had this process going on for years. So if you see it, what do you do about it? Well, the classic thing we do, we have the bias, and until we get a little bit more analysis done, I'm not sure I can say this is an absolute thing to absolutely do, but in the sense of being as cautious as possible, what we do when we see the PTH level get to a range that we're concerned about, and that varies in different assays, we would try to modify the therapy so that we can effect a drop in the PTH level. And most people are on calcitriol and phosphate, and the way the balance works is that if you are overtreated with phosphate, you're going to tend to drive the PTH level up higher, overtreated with respect to how much calcitriol you're on. Likewise, if you're undertreated with calcitriol, the same thing could happen. So what we often do to manipulate that situation is either to decrease the phosphate or to increase the calcitriol. And the decision between those two things depends a lot on other factors that are going on. For instance, that's when we look at those urinary calcium levels. And if they tend to be high, we don't want to increase the calcitriol too high. If they tend to be safe or low, it's time to bump the calcitriol up. If the bones aren't healing very well, it's kind of a call for increasing therapy. If everything looks pretty well healed, we feel and we're more comfortable dropping, say, the phosphate than increasing the calcitriol. So it's kind of playing with those different levels as to how we manage it. Now, this situation can get out of, even with the best of management, the situation can get out of control because there's something seems to be fundamentally different about the parathyroid glands. So some patients, and this is really more evident in adulthood, but not always, in some children too, we get to a situation where we can't just manipulate those two drugs. The PTH level's too high, and maybe the hypercalcemia has started. We've got to do something. And in the old days, we did a parathyroidectomy, and some of you have probably had your parathyroid glands removed. Now there's other options, and one of them was related to the studies that we were doing, trying to use a vitamin D analog that specifically drops PTH, and that was the paracalcitol versus placebo study that we did, and we are actually analyzing that data now too, and we have to go through some more iterations, but it looks promising. It looks like paracalcitol can drop PTH significantly. So that may, if that does tend to pan out, then that could be an option. It's not a perfectly safe medication. You can run into bumping your calcium levels up a little bit higher with paracalcitol, but not as much as we tend to see with the calcitriol. So it's going to be a calcitriol-like drug with a little less hypercalcemic activity. Cinacalcet's the other drug that has been used in this situation, and there have been some patients that we've treated. Even recently, I have had a child on this who got into the situation where we couldn't treat with calcitriol or phosphate anymore. And when we took her off all of the medications, her rickets recurred. The x-rays actually reverted to overt rickets within about 4 or 5 months. So it didn't take long to see the rickets recur without any therapy. So we started using the cinacalcet in her, and that's actually been successful, and we're trying to wean it off now. But that's a drug that has been anecdotally used, and a placebo-controlled trial in XLH for it has not been done, but I think time's kind of ripe for that. We've actually tried to get some funding for that through NIH, but it hasn't panned out yet. The other thing that people have done is just take people off therapy entirely, and sometimes it's a stopgap measure that has to be done. But as you see, sometimes the bone disease will go down. You'll have worsening of the bone disease without the standard therapies. So in short, I'd say in children a minimum of every 6 months. If there's been borderline PTHs, we'll even do them every visit. There's sort of a change in the game in adults because there's a little more propensity to this, but I would think most people would agree that at least every 6 months, maybe every year, it's important to have that PTH level checked. So it's a long answer, but I wanted to sort of tell the story so you could sort of pick up the thinking about why those recommendations, why we say those things.
Thank you, Tom. The next question, dental issues. Are there any useful preventive measures to stop abscesses or fill in the microfissures? If the tooth can't be saved, what's the prognosis for XLH patients who have implants? i.e., are there issues with healing? Should adult supplement treatment be started or increased?
I think it's for me. I would like to use the board.
Sure.
Can I?
Sure.
So to understand the dental effects, we'll do a normal tooth structure and what are the changes in XLH and what treatment we should be doing so that to go from normal, from XLH to normal. So we'll after so many years, I can draw a nice tooth. So it's a molar. We'll think that it's a lower molar. So this will be the bone around it. So this is a normal adult or even primary molar. You can think of it as a baby, or so it's a. We'll say this is one. So every tooth has an outer structure which is enamel, and then inside is little. Let's see, this is the pulp. Okay, and this part, outer part, is dentine. And then it's encased in cementum, which is the connection between the bone here and the tooth, and that's what holds it. There's a periodontal ligament. So this is a normal tooth structure, outermost enamel, which is the strongest, and there's dentine, and then there is pulp. What happens in XLH with rat? That this enamel is normal, but the denting, instead of being till here, is a little higher, and it's not as strong. So I'm drawing this. It just means that the denting itself is not very strong. And the pulp, if you see, there is this much distance in this pulp. The structure is called pulp horn, and pulp is the one that has all the nerves and vessels. Basically, pulp is the heart of the tooth, and everything else is just protecting it. So instead of pulp horn being here, these are just horns, so they call this, it's very high. And for a normal tooth structure, we all know that there are enamel fissures, enamel cracks. Everybody has those. The tooth is, like everything, the tooth structure is not perfect. The outermost enamel, although it's the hardest substance in the body, it still has some micro cracks where some micro leakages can happen. What happens in the tooth with the XLH is that this dentinal area is more porous. So I'm showing porous with the red. So let's say if so there are three kinds of insults: chemical, thermal, or iatrogenic. So let's say that due to whatever our daily dietary practices or our cleansing habits or whatever, there is a bacteria that wants to come from here. So what happens, the dentin is the reparative part of the tooth. Dentin is the one that is going to protect this underlying pulp even if something enters from here. So here, this is a healthy tooth structure. The dentin will fight it off, and believe it or not, dentin will form different layers to prevent this pulp, because once it gets into the pulp, that's when you get the abscess and the root canal, the whole thing is needed. However, in a tooth with XLH, the same outer structure, but this thing is porous and the pulp horns are so high, the same in cells. This dentin, which is porous by structure due to the decreased calcium and phosphorus levels, and due to the mutation, it permits the entry of bacteria. And that's what causes the subsequent necrosis, that is dying of the pulp, and then the abscess and all the other changes that happen. The cementum itself is also weak. That's also the inherent part of the disease. So what causes the abscesses? Once this entry occurs from here, it goes from here, and that's how you see the abscess on the gum here through the bone. Now, what are the ways we can do to go from here to here? Does anyone have any questions so far? So one thing is, of course, if you have the disease or if the child has the disease, the first thing is to start early. First dental visit is recommended at the age of 1. What it gives is, it gives an opportunity for your provider to understand the disease better and go home and do the research that is needed. Second is periodic recalls. Instead of going every 6 months, you can talk to your provider, whether pediatric or adult, and you can go 3 times, every 3 months, so that everything is being checked, you're in good health, and if there is any issue that comes up, it can be treated right then and there. Other one is sealants. So sealants, what they do is that these grooves and fissures in the enamel, you put the sealant on, you're sealing this. It's just like reinforcing. The example I give parents is like, if there is a piece of iron that is continuously being subjected to wear and you want to prevent it from rusting, you will put a varnish or something. That is what basically a sealant is. So you'll put a sealant. There are different kinds of sealants. You can talk to your provider. Even when the child is really, really young, there are sealants that you can put that will be successful even if there is saliva. So the need for sealant is that you need a proper isolation. That is, there should not be any saliva or anything when you're putting this sealant, but in children it can be a consideration. So there are kind of sealants now that even release fluoride, that's one. And secondly, even if everything is wet, you can still put it on. Second is, okay, you did everything and now let's say you have the abscess. So in primary tooth, it's easier. You remove the tooth and you put the space maintainer. In adults, you have choices of doing a root canal and then, I'll write it here, a root canal and then a coverage. There has been some research that says that even if you do the root canal, you might not be able to prevent it from abscesses. But of the literature I have read, it would fall under a complicated process because the tooth inherently is weaker than this tooth here. So what I recommend is that if you ever need a root canal, you can talk to your general dentist. They might be able to do it. It might be an easy root canal that can be done, but you can talk to them and see if you can go to an endodontist. How does it differ is that they have more training, 3 years just doing root canals, and they have all the tools that a general dentist might not have, more advanced tools that can cause less trauma, and then it's a successful root canal. And then you can go back to the provider for the crown. Earlier there was some theory that in children, if a child has XLH, you can just prophylactically go ahead and put a silver crown so that they don't get the abscesses, but we do not need to do that because even that sometimes does not prevent the abscess. Then third is the fluoride. So check if your community water has fluoride. What fluoride does is it makes the tooth structure a little stronger, the enamel component. It binds to the tooth so it's less prone to decay and it's less prone to break down. So if you have the outer coating which is stronger, even though the inside is not, you're still helping the tooth. And there has been a lot of controversy regarding fluoride, but the point is, too much of everything is bad, so you have to take the age and weight was the right dose, and it's not harmful if it's taken within it's actually beneficial. Then there were if everything else fails and now you need an implant. What happens when you need an implant? So implants currently have a failure rate, it's a broad range, depending on the paper you take, between 6% to 30%. It's different papers from all over the world. But, so they say the dental implant is very, very successful. But there's one group where the failure rate is highest, that is XLH. But what that has done is that I saw recently between 2007 to now, a lot of research is actually going on with XLH patients for what can be done. The studies are still being done on mice, but there are results that say that when the vitamin D levels in mice are lower, the implant failure is very high. So now there are actually some implants which are still being tested in mice, which the implant comes coated with vitamin D so that the bone integration is stronger. So there is hope. Although it's still in infancy, I would say. But if you need an implant, again, I would suggest that go to a specialist. Not because a general dentist cannot do it, but specialists have greater tools, they have everything that is needed, and they have probably more expertise doing the same thing for a higher success. And even if implants are successful, if the implant fails, it's not still end of the world. You can go for any other kind of tooth replacement using a partial denture or a complete denture. Any other questions for me? Yes,
Yes, I have a question, Raghbir, and if my associates that are here are familiar with the question that I'm going to ask, I apologize for being redundant, but I'm unaware. I know that we've had generalized discussions previously about we feel that the dental industry is not as knowledgeable as other areas might be in regard to XLH. You were mentioning that in regard to the person with XLH, to speak to their dentist about possibly going to an endodontist, I think you mentioned?
Yes.
Now, if this is an unfair question, please feel free to say, I think that's an unfair question. In your opinion, would endodontists be more familiar or knowledgeable about XLH than, pardon the expression, a normal dentist?
So, I think Thank you for the question. There's a question, I'm going to use the same. Even if a professional is very good in their chosen field and do not know about XLH, I think I have a question for me. And I had said that what you can do is get a letter from your primary provider, internal medicine or endocrinologist, that says that what are the different issues that are with dental. And XLH Network has some articles, and then there is a brochure, okay? Even if somebody doesn't know. What happens is, because it's such a vast, in dentistry, it's so vast, and there are different conditions, and for every condition you have to know what precisely does that cause for dental. And sometimes, even if they're not aware, your knowledge can help, your self-advocacy. Your general dentist can give you that letter once you have the conversation that you want to go to an endodontist. What an endodontist has is an expertise of working with very difficult cases that a general dentist might or might not, based on the rigorous training they went through. They go 3 years extra for doing just root canals. Secondly, if your tooth is more friable and fragile condition, and it is already in research, it says that there's a higher failure rate for root canals, you're better going to endodontist and have at least that expertise. The tools they have microscopes, and they are much more well-versed with the current literature. And I can tell you that the endodontist at Yale, when I mentioned to him we were taught, and when I mentioned to him that, yeah, I'm doing this XLH research with Dr. Carpenter, he knew a lot about it. So I think that it's part of the training that they know that there's a spontaneous absence, the patient needs root canal. Right? I hope I have answered the question. Thank you. You have another question?
I have a question. I have a question about sealants.
Yes.
Our two daughters have XLH and have not had any dental problems until very recently, and they're both in their late 20s. How often should they get sealants, and how long should they last? And can a young adult get sealants to prevent any further decay or?
Okay. So in general, sealants are placed at the age of 6. Because that's when the first permanent molars come in, and these molars last as long as an individual's age. So sealants are placed at the age of 6. It depends on how helpful the child is going to be. Although there is no shot, none of those things are involved. It's just involves just opening of the mouth for the child. Again, it depends on the variability and condition under which the sealants were placed. Isolation, that the dry tooth is very important. If the child is not able to help with it, you might see yourself doing the same sealants every 6 months. Now, every provider is different, but I can tell you from my practice, what I do is I do the sealant if the child there's another condition called molar incisal hypoplasia, where it's very, very important to place the sealant regardless of child's age. So what I do is I use a different kind of sealant which releases fluoride but doesn't have to be dry and isolated. So I put these sealants on, and I tell the parent that, listen, even if they're lost in 6 months or so, when you come for your 6-month visit, we just touch those up. Okay? So it depends provider to provider. You can talk to a provider, but usually when I put the sealant at the age of 6, it lasts. I've seen, well, my research, I have seen that I have seen my 3-year, and I saw that I placed something 3 years ago, and it was still there, and it's very successful. 78% successful in preventive caries overall in literature. And yes, young adults can get the sealants. If your daughters are in 20s, most likely, that's the other point I forgot to mention actually. Children now, because the therapy is starting, because we understand the disease better and there's more therapy, the children now do not have as severe dental implications or complications as people in 60s, because at that time there was not much in dental and we didn't understand the disease also very properly. Thank you. Thank you.
Just a question that I thought was an interesting point you made. We know that there's intrinsic defects in the tooth itself in XLH, but when you get to the implant stage, I'm wondering if the take of the implant, your implication is to me that the take of the implant then becomes dependent on the surrounding bone. And so this might be a situation where if people are debating about the positive or negative effects of overall therapy for XLH, that the dental implant may be a better take because the bone might be less osteomalacic if therapy is being undertaken. So I'm wondering if it might be a good idea before an implant to have some period of time of the standard therapy to prepare the bones for an optimal outcome. Am I thinking about that in concert with what you're saying?
Yes. So actually there is a question, I was planning on answering it later, that what happens if the bone is osteomalacious? It does not take up the implant, and that is the bigger problem because there's not enough phosphorus available for that osseointegration to happen. So if there is some supplementation in therapy within the norms by the endocrinologist, nephrologist, yes, it will help with the uptake of the implant. Yes.
So this suggests that before any implant, you must be reviewed by your doctor, have your levels tested, share that information with the dentist that is unfamiliar with XLH levels. So there has to be coordination between your medical doctor and your dentist before an implant, correct?
Yes.
Okay, I just want to be clear on that because that's pretty complicated, time-consuming, and beyond what most of us have had to do to get dental care. But it's wonderful to understand that. Thank you so much for clarifying that.
Thank you.
So we'll move on to question 3. In the absence of a diagnosis of serious osteoporosis, are bisphosphonates useful for treatment of XLH? Are XLH patients equally at risk for osteoporosis or somewhat less likely to develop it, given the generally oversized bones we have? This is a very good question, very common question.
No. I have a few intuitive responses to that, but I would yield to your expertise on that. I would suspect bisphosphonates would be a funny drug in this disease.
Yeah, I can, pull my pediatrician card out now and say that I rarely see serious osteoporosis in the setting of XLH. So I don't have any experience with this dilemma. But some years ago, who knows how relevant they are today given the dosages used and so forth, but some years ago, patients, and these were adults and they weren't XLH patients, but patients were treated with bisphosphonates that had some underlying cause of osteomalacia in the early years of bisphosphonates. I think primarily used in those studies was etidronate. But the osteomalacia got worse in those patients. And so there's always been this, sort of prohibition about using bisphosphonates in an osteomalacic process. But, I kind of think in the current era that the objective answer probably isn't there, at least I haven't seen it, but there's this background sense that you could do more harm than good.
I can just clarify a little about those drugs, which are so widely available, they worry me because they get thrown at bone patients. What Dr. Carpenter's talking about is the first drug that came along, a bisphosphonate, at the same dose in which it stopped bone turnover would create osteomalacia in bone and therefore exacerbate the underlying disease by another mechanism. The new drugs have a wider therapeutic margin, but they all seek bone, calcium phosphate in the bone to bind to at bone turnover sites. And this is why I say intuitively, there are pockets throughout bone, even as you're doing well, that remain osteomalacic. And intuitively, it's the wrong drug to put into a system to bind randomly to these sites where there's adequate calcium phosphate mineralization. We have many times when we've used our intuition been wrong. And the other biochemical effect of a bisphosphonate, which are used for osteoporosis, is that it impairs the dissolution of mineralization as well. That's a property of all of them. So it may be at some time we'll learn about a role other than the osteoporosis indications for protection of bone and strength in this disease. But as Dr. Carpenter says, that there's no data out there to indicate it at this time. As we were talking before this, each of you is different, and there may be somebody walks into my office as an adult, and I say something completely different. So I reserve that right.
And I want to just emphasize the point you made about stopping the bone turnover. What that does is keeps the normal mineral that leaches out of bone into the circulation from happening, so the phosphate levels actually drop on most patients that are on bisphosphonates. So there could be that side of the equation too that could be affected with the use of them. But we're talking theoretically, and theoretically it hasn't made much sense. So there's not been a great justification to start doing it.
What drugs would be considered bisphosphonates?
Yeah, the classic one is Fosamax or alendronate, and Actonel, which is Residronate, which is also used out there, and more recently Boniva. So that whole class of drugs are all work in the same way with that backbone that sticks to bone and then somehow affects the where they differ. Each one's a little different in not that backbone, but the little side chain off the molecule that affects the bone resorbing cell to stop working.
I'm going to jump ahead to question 7 because it's somewhat related to question 4, but it's a little more comprehensive, I believe. Joint replacements. Are there any treatment differences for an XLH patient compared to other patients having a knee or hip replaced, e.g. bone healing issues? And what are the recommendations for adult supplement treatment prior to and after spinal surgery?
So as I said, I'm a pediatric orthopedic surgeon, so I don't do joint replacement in my practice since I see children and young adults. And the last joint replacement I was involved in was in my residency training, so you can take what I say with a grain of salt. But I do want to try to answer this question. If you don't mind going to my PowerPoint, it's called question 7. So I just wanted to describe or explain the normal alignment of bone, and then I think it'll be easy to understand the complexities of joint replacement in XLH or any population with a lot of bone deformity. And I can talk about what type of orthopedist you probably want to see if you're looking into joint replacement. So this is normal bone alignment, and you can see there's a straight line between the hip and the ankle, and that generally falls pretty much in the center of the knee. So in XLH, it's very common to have bowing, so that line will fall more toward the inside of the knee joint, or you can have knock knees as well. But in general, joint replacements of the knee and the hip are designed to be placed in relatively normally aligned bones. So that's where one of the complicating factors comes in with XLH, is that so you may be trying or attempting to put a joint replacement in bones that are very bowed, not necessarily right at the joint, but right above or below the joint. So for example, a hip replacement or a knee replacement, there are, for a knee replacement, there's short stems to fix the implant to the bone. They're designed to go into this part of the bone here and here. So you can imagine, and those are designed for relatively normally aligned bones. So trying to put a knee or hip replacement into a bone that's very bowed in this region, that's a complicating factor. So what has to happen if that's the case is there may have to be an osteotomy or bone cut in the bone to align the bone to a more typical alignment before an implant could be placed. So I have another slide. And you can see how, and this is a child, but let's pretend the growth plates weren't here. But you can imagine trying to put a stem that's designed for a more straight bone here into this bone isn't going to work. Maybe one more. All right, so here's an example of an adult with XLH and joint replacements. So you can see this person, you can see above the joint replacement, there's this person previously underwent correction of their curvature of their bone. Oh, thank you. So you see it, and sometime in the past, you can see there's been evidence of some bone cuts and some attempt at obtaining a more normal alignment. Well, you can see this is a person who had a joint bilateral knee replacement done, and this is an XLH patient from this article I found. This isn't anything I was involved with. But this is, so in general, there's very little information I found on joint replacement specifically in XLH. There's a slightly wider literature in joint replacement in people with bone deformity in general, whether that's after a fracture that occurred or some other metabolic bone disease. So that exists, but this is one of the only articles actually specifically looking at hip and knee replacement in hypophosphatemic rickets, and this was out of the Mayo Clinic in Minnesota. And this paper had only 8 patients. So that's pretty much it, specifically for XLH and joint replacement. So it can be done. Can I have the next one? And this is from the same article, and they're looking at a hip replacement. So you can see here's the XLH patient before the hip replacement. This is a side view of the hip, and you can see, as is typical in XLH, there's a bow forward in the femur here, and you can see that hip replacement is designed with this straight stem here, and that straight stem isn't going to be able to be placed down this bone. So what this surgeon had to do was cut the bone, straighten it to a more typical position before the implant could be placed. So it's much more complex than just a straightforward joint replacement for osteoarthritis without, in the setting of a normal alignment. One more slide. And here's so this is a paper I found looking at knee replacement, and they call it severe extra-articular deformity. There was one patient out of, I think there's about 20 patients in the study with XLH. Most of the people, I think, had post-traumatic deformity after a fracture of the bone was in a poor position. But you can see there had to be a bone cut and alignment here before the knee replacement was placed. I don't know if it was done at the same setting or a different setting, but just an example of how the bone sometimes needs to be straightened in conjunction with placing the joint, the new joint. So it can be much more complex than a typical joint replacement. So, in light of that, if you are looking at a joint replacement, I'd recommend going to someone who only does hip and knee replacement, an orthopedic surgeon that just does hip and knee replacement, probably someone who has a more complex practice, meaning they do a lot of revision surgeries, so people who need their second or third or even subsequent after that joint replacements. So someone who's comfortable doing a lot of complex procedures and joint replacements of the hip and knee is someone you want to seek out, not someone who does joint replacement and a lot of other things. So you probably want to go to a major academic center where someone is comfortable on a large portion of their practice is made up of complex reconstruction, complex joint replacement. The other issue is longevity of these implants in someone with XLH or any bone deformity that isn't completely corrected. And I don't think there's really an answer at this point. So just like, can you go back onto my alignment slide? So just as our joints function best when the knee joint and the ankle joint are parallel to the floor. So that's a normal position, and in this way you can see the weight of the body is nicely and evenly distributed across a surface that's parallel to the floor. So in XLH, with a lot of bowing or knock knees, those joint surfaces, if you're thinking of the knee, isn't parallel to the floor. It's tilted one way or the other. So there's a asymmetric distribution of force across the joint, and you're going to get excess wear on one side or the other. And think of the same thing with a joint replacement. So you have a plastic and metal now in one of your joints. And just like your native joint, if that replacement is seeing asymmetric loading because there's still some bow-leggedness or knock knees, you can imagine that joint replacement might wear out more quickly than it would in joints that are perfectly aligned. So those are some of the issues to think about if you're thinking about a joint replacement. In general, joint replacement's a wildly successful operation for restoring function, at least in your average patient with degenerative arthritis. So I think it can probably be a very successful operation in someone with XLH who's really suffering with bad joint disease and is really disabled by that. But it's not going to be necessarily a straightforward joint replacement. Any other questions?
I have a question. When you do it in children, which is slightly different, is this very vascular bone? Is it different from usual bone?
In my experience, no. And I don't do joint replacement again, so I'll do deformity correction, so correcting the alignment of the bone.
So you don't see excessive bleeding as a risk?
No, I have not in these patients. I haven't seen it reported.
And then I just have a question. If it's okay if anyone's had a joint replacement out there who's done very well or not done well. Has anyone gone through it as an adult? Maybe you could tell us.
I have a question, comment related to this. Thank you. In 2005, I had I guess you'd call it a standard joint replacement on one knee. And then in 2010, I had what I call a specialized joint replacement on the other knee. The second knee was much, much better. I still have a little bit of wobbliness in the right knee, and it clicks a lot. The orthopedic surgeon advised me that he had to make it so that it would move in order to accommodate the bow in my leg. It would move as I walked, and I can feel that clicking and moving back and forth. My other knee was a different orthopedic surgeon. He took a CT scan of the knee, sent it to Sweden, and had a plastic jig model of that made, sent it back to the US, and from that jig, they built a specific knee to match the jig, to match my leg. And then in surgery, he used that jig to cut the right shape in my leg and put the knee in. Now, I still have healing issues and that sort of thing, but the stability of the knee and the flexibility of the knee are 100% better on the second one than the first one. And so this man specializes in hip and knee replacements. If anybody's interested, I can give you his name. He's in Texas. I'm sure that his knee is going to be really beneficial for an XLH patient. I really didn't think of it that greatly until we started talking about it today. But if anybody's interested, I can let you know about him. Yeah, he did correct the mechanics so that the leg doesn't feel like I'm walking bowed as much as the right leg does, or like I'm walking crooked. So it's much more stable and it feels straighter.
Would you feel comfortable sharing the name of your clinician?
Sure, his name is Tyler Goldberg.
Thank you.
And he's in Austin, Texas.
Thank you.
Oh, it just says a rheumatologist who takes care of patients with other kinds of arthritis, that one of the advantages of going to a thoughtful specialist, echoing what you said, is that there are other joints. You kind of, if you take somebody's knee out and put in a new knee, it's going to change the way you do work through the ankle and a hip. And an orthopedist with experience not only in knees and hips, but somebody who's taking care of arthritis patients, so understands that when you get back up, the forces that allow you to get up and walk are going to be shifted during healing. This is very important. You're not just putting in a knee. As you showed, you're changing the alignment of the extremity. And for adults, there's just a little less give. You know, we are who we are by the time we come to these surgeries. And so that kind of thoughtful approach makes an enormous difference to your recovery. I don't know the bone piece and the healing around the prosthesis, but I know for my patients rehabbing from rheumatoid arthritis or other joint replacements, these considerations put them on their feet. And we hope it's once that they go through it.
Apologize for talking so much, but our two daughters, while we're on the subject of operations and bones and not to do with replacements, however, our two daughters, I'd just like to say to the parents of small children here, were very diligent about their therapy when they were younger, as Dr. Carpenter can attest to. And so they did very well. And as they got older, our oldest daughter was very diligent still about her treatments, but our youngest was not. And our youngest had 4 osteotomies. And after going off to boarding school and then going off to college and not keeping up with her therapy, she had fallen just a couple of years ago, and she cracked her femur right at the site of the plate. And Dr. DeLuca had done her previous surgery, so we did see him again. He took her even though she was not pediatric. And his comment to me when he came out of surgery was, what is going on with her bones? They are like chalk. She's not taking her medication. So I just want to reiterate how important it is to be really on top of your young children and your young adults as they leave home to continue to take their medication. I guarantee you she's taking it now, but it made a very, very big difference in what happened to her when she fell. So,
Thank you.
I'm going to just jump in real quick. Not till later, so, but I just wanted to, my name is Dr. Keith Steibigal. I'm an orthopedic physical therapist, and I primarily treat the adult population. So I wanted to just jump into your segment a little bit on that with the joint replacements. You know, as the panel said here, it really can make a huge difference on quality of life, because as Dr. Sharkey said, it's not just that joint you're correcting, it's the joint above, below, and everything around it. And as a movement dysfunctional specialist, which is what I do, I look for those challenges. And if one joint can be corrected, it can make my job much easier for the joints above and below and the quality of movement thereon. The one thing I will say, if you choose to go forward with the joint replacement, and the rehab portion can be as important sometimes, if not more so, than the actual joint replacement, because if it's not done correctly, you can have a phenomenal new joint with awful movement, and that does you no good. So the one thing you want to relate to your practitioner is your underlying history. I believe with this case, and I think probably the panel would agree with this without having to be rehab specialists, is the protocol for rehab will change a little bit here. Typical joint replacement protocols, we have time frames and where we go from one portion to another portion of passive range of motion to a little bit more aggressive range of motion to stability and strengthening. That may change here, and I think it's good for you to know that those time frames may not be the same as the other population, and to go into that knowing you may have to put a little extra work into that, and to work with the practitioners, and you may have to work with your insurance companies because they're becoming their own challenge and how much time I can have with you in my office, because it's just numbers and mechanics to them more than people. So that's my 2 cents, that your protocol for rehab may change here in terms, it may take longer for those joint tissues to become solid around the prosthesis to allow you to have better weight-bearing status. I don't know if you went through the same thing, but that's something to consider as you sort of map out your time frame there after your surgery. Okay.
Thank you. I'm going to progress to questions 5 and 6, which are interrelated. They both speak to the same issue. One is talking about spinal stenosis and other related calcifications of the spine. And the next question is about calcifications and enthesopathy. I believe they're irreversible, but are there any recommendations for either preventing them or minimizing the damage once they're present? What are the locations where they are most common in XLH patients, and just how common are they? So I'll make a few comments, and then I invite my colleagues to...
I just wanted, before we left the replacement story, just one piece of the question that was in there had to do with preparative treatment, or how does healing go, and just to sort of echo Janet's comment that, you know, in children we have everybody on therapy, so were they having these kids, there would be no adjustments. But by and large, I would say less than half of the adult population is routinely treated, but they may come to such surgeries. And if that's the case, I think there is a good rationale for treatment, medical treatment, to prepare for and to potentially assist with the healing of the intervention. And that's something that needs to be coordinated, much like we were saying for the dental group.
Fantastic, thank you. So these two questions are related to the calcifications that occur in the disorder. And you probably all recognize that this is a very paradoxical feature of the disease, so that you have a mineral wasting disease, yet you're having calcifications or mineralizations of some of the soft tissues. This is a dominant feature of the disease, of the adult disorder, and it does not appear to be related to treatment or not, because whether patients are treated or not, they often will go on to develop these bone spurs in the tendons or ligaments or at the margins of articular joints. That said, based on the data generated from the mouse model of the disease, the calcifications or mineralization of the tendon and ligament insertion sites are likely related to a compensation to try to make that insertion a little stronger, because the insertion is in fact inserting into a softer bone. And the analogy that I use is a tent usually has 4 pegs in the corners to hold it down. If it rains a lot and that soil becomes really, really soggy, one way to stabilize that is to add a lot more pegs into the ground. And that's effectively what seems to be happening in the tendon and ligament insertion sites, and that is those cells that are part of the strong part of the insertion are proliferating. There's a whole bunch of the cells now, and these cells are of the mineralizing type. So it appears to be forming a bone spur, and in the mouse model, the bone spur really isn't bone like in our long bones, but it's mineral, it's a cartilaginous mineral. It's effectively the same exact mineral though, it's calcium and phosphate. So the difference between these, and they're called enthesophytes, or part of the enthesopathy, enthesis is an insertion site. The difference between the unaffected aging population and the XLH population is that unfortunately this disorder, this manifestation of the disease occurs a lot earlier. So we'll see patients in the XLH community at Yale that were as young as the 20s, 30s, 40s developing these. The other thing that's different from the normal aging population is the prevalence of these mineralizations, where often you'll see many sites affected. Those sites that are most affected are those that are most heavily loaded. So the knees, you'll see mineralization of the patellar and the quadriceps insertions. You'll see mineralization of the Achilles insertion in the heel. Probably the most disturbing one and the most prevalent one we see often is the ligament that runs along the spine. So you'll see that there's a great stiffness in the neck or inability to kind of manipulate the upper lumbar spine. So the bad news is that there really isn't any treatment for this. Our second panel today will talk about interventions that we can do to help deal with the limited mobility and the pain that comes along with this, and also sort of the accommodations that you can make in your home to help you do your day-to-day lifestyle things. So the data so far in the patients is that it is usually by age 40, most patients have some sort of mineralization of the insertions. The bone spurs at the margins of joints probably has a different etiology. That's probably secondary to degeneration of the articular cartilage. And these bone spurs that form at the margins of the joints are likely forming to help stabilize the joint. Again, it's another attempt by your body to compensate for that degeneration. So the data, again, this has not been confirmed in patients, but the data from the mirroring model suggests that continued treatment helps to keep that cartilage more normal. And we know that because in the untreated condition, the molecules that provide strength in the cartilage, that is strength that helps to resist compressive forces as well as tensile forces, are all upregulated. So your body's trying to make more of these molecules that help give your cartilages and your tendons strength. So when we treat the animals, the levels of these molecules start to return towards normal. And that suggests that that's helping to restore those normal mechanical forces to the joint. So again, this right now is anecdotal. We need more research to confirm this. Does anybody on the panel have anything to add about the calcifications and the population?
I have some slides. I don't know if this is the right time, but I would say, as somebody who's taken care of patients for 30 years with arthritis, that it's not all bad news. That although these things evolve, and although we see them happening, they're not clearly, to me, always the source of pain. So we do X-rays or MRIs on the general population of adults, and we see about 20 to 30% of those people will have disc herniations and no pain, right? So the struggle as a rheumatologist is understanding the anatomical correlates of pain and what's driving it. Is your back pain due to kind of a last straw effect, increased mineralization? And what's driving that? Is it vascular? Is it the disease process itself trying to kind of buttress bone? Is there an inflammatory phase, which as I listen to adult patients, I'm beginning to wonder whether there may be an inflammatory phase to this enthesopathy of the spine. And so what I would say is that I've taken care of so many patients whose diseases are supposed to be progressive, and they stop, and people do better. What is that? What is aging? What is adolescence? What are the other factors that permit us to go on and live a life and have this spell, even though we have the disease? We don't really understand. But I think some of it is exercise, some of it is muscle strength, some of it is other factors within your own body, because you just don't have an XLH gene. You've got a bunch of other genes there too. And how these interplay to make a disease like arthritis do this in your life, we really don't understand. We don't understand with your disease, and we don't understand with good old osteoarthritis in the adult. So I would just like to point out that we can see these changes, and Carolyn's work and Dr. Carpenter's and everyone at Yale has been so informative to me in hoping there'll be treatment. But I have every reason as a clinician to believe there will be, because I've seen this happen in rheumatoid arthritis, where we have found just medicines that change this natural history. So yes, it is a natural feature of disease and aging, but it's probably going to be erratic. And I'm an incurable optimist, and that may translate into being stubborn. But I see that I think these things can be managed with very good physical therapy too. Not always easy, but I would keep in mind that they don't always stay. We don't know what makes them go away, but they can go away, and your X-ray can look exactly the same. Okay.
So I can sort of fill in from the clinical side from the surveys that were done on many of you folks who, again, graciously came into the clinical research arena and got X-rayed in all these various spots. And what we saw in that survey, and this was, you know, a single point in time, so we don't know the longitudinal story here, but we didn't see the evidence of the entheses until usually people were in their 20s. I think there was one person that we saw it at 19, but most of the time it was beginning in the 20s and 30s, again in a cross-sectional population. It was more common in the men than the women, but you know, still significant proportions of both demonstrated this. And what we also saw, you know, some people never got it, or at least some of the oldest people in the study didn't have any evidence at the sites we looked, and yet if you plotted everybody out over their age, the older people tended to have more sites involved. So there may be some progressive status of this when you look at a whole population and at a single point in time. It really isn't one of the pediatric elements of the disease, but there does tend to be that male-female difference that seems to happen with a lot of other things in the disease as well. But in terms of the demography of it, that's kind of where we are. I think the other question that we often ask is, what about the other variants? And in work Carolyn's done in collaboration with folks in Montreal, some of the people that have, I think one of the autosomal recessive variants of this have had pretty severe extent of this enthesopathy as well.
Don't they fuse with age their SI joints too? Is that a common feature of, in the I think it was 85 paper with Paulison, and that study of just before there was treatment, just looking at radiographic changes, it seemed like that tracked with age as well, which can give people a stiff back for very different reasons.
Yeah, I think that is in that paper. We didn't specifically look at that. We may be able to go back from the films and actually ask that question too.
And again, this I ensured that for the second session today that this be a major emphasis of the program, because it really does come to dominate the clinical picture in adulthood. The next question, this question in short is just, how does a patient talk to their clinician who's not, or their endocrinologist who's not an expert in XLH? How do you approach the person? How do you talk to them? And how do you converse with them? Would any of our panelists like to tackle that?
I will.
Just do a referral.
I'll just answer from the dental perspective, because I think Bill was referring to this question. The thing is that there is very little understanding of XLH disease as such within the dental component. So I think what is important, what I have seen is from the patients when I was doing the research, was that a lot of those patients had a letter from Dr. Carpenter, which did mention about the dental abscess. It didn't specify what treatment but it did mention what they were taking, what medications, what other medical histories were there, and if there were any dental abscesses or not. So I think that is one letter you can get for either your pediatrician or physician. Second is, I had mentioned the brochures from the XLH site, which are very helpful, and other one is to get a treatment in an academic center, because they're more research oriented, they have more resources, and you don't have to do the whole runaround, because they have almost an orthodontist for braces, endodontist for root canal, and pediatric dentists, or even if hospital dentistry is needed, right there in the facility. And then I can tell that my generation pediatric dentists are very, very well aware of the disease, because I took my boards last year in October, and everybody knew about XLH. And then they knew that I had done the research. This is just before the exam, and they were asking me, because apparently there's a question on the boards for XLH and hypophosphatasia. So now a lot of, most of the pediatric dentists who are board certified, they know about the disease. So,
do you have any suggestions for some of the, for some of the younger parents here? In speaking to some of the parents last night, in dealing with their insurances for, like for instance, you suggest as a dentist that every 3 months would be a good, for them to go. Most insurances won't cover that. Right. Also, you know, I've talked to people who've encountered physical therapy. That physical therapy has been suggested for their child, but insurance won't pay for it. Right. You know, those issues. It's great to have all of these treatments, but if your insurance can't pay for it, or for instance, even just the phosphate, that if it's a typical certain phosphate, your insurance won't pay for it because it's over the counter. So how do these young couples go about finding information that they can give to their insurance companies to help that process?
Can I speak to that?
Sure.
Be a member of the XLH network. Use our website. Go to the medical information that's on our website. Don't refer your doctor to it. Print it out, take it to them, spoon feed it to them. Make it easy. Medicine is too busy, too complicated. Insurance is not our friend. Band with us. We have to work together as an organization to educate the medical community and the insurance providers. Also, we have to set the precedent. We have to make our case. We have to demand good health care. So that's the purpose of our network. Individual doctors can be sympathetic, understanding, but their battle is not to be sure that it's paid for. That's not their business. It's to treat us. So we are our own champions, so please join us in that. And the young people, pay attention now. It's the future of your children. It's your own health when you get older. So that's my 2 cents on that.
Thank you, Becky. And I just want to add a footnote that this is one of the issues that will be discussed during the second panel, because oftentimes it is more difficult for people to get occupational therapy or physical therapy support, but yet these services are available and they are covered if you know how to negotiate the system. The next 2 questions are related to kidney function. One of them talks about the renal calcifications that you'll often hear about and that Dr. Carpenter spoke about earlier. And are they reversible? What can be done to help perhaps erode them a little? Is there anything to counteract the risk of getting calcification or renal calcifications? The next question is somewhat related. Often there's a perception that there's something wrong with renal function in patients with XLH. So I think that, and again, that's often taken in the context of this risk of renal calcifications that occur during treatment. So maybe we can approach both of these questions together.
So we'll start by talking about the nephrocalcinosis. Well, they're interrelated, so we'll sort of talk about the nephrocalcinosis issue. I think different practices have come about based on the anecdotal experience of different places and different doctors, and so there's some variance, but I think the general philosophy behind it is pretty similar, even though the exact schedule of testing may be different. In our setting, when I've talked with people around, we may be a little bit on the lesser side of the amount of phosphate we use in our therapeutic regimen for children. And at the same time, we might be using a little more calcitriol. Everybody's within the same range, but if you kind of fine-tune it, I think when we compare with others, we might use a little bit less phosphate. And so what we've seen, and some of that's been driven, frankly, by this goal of keeping PTH as low as possible. But what we've seen over time is that we don't really see that much severe nephrocalcinosis in our population. Now, if you want to see the best description of the nephrocalcinosis, there's a 1990 or so, maybe 1980, late 1980s or 1990 article in the New England Journal of Medicine by an author named Verge, V-E-R-G-E, and I think his initial is C. It's an Australian study, and they really first, in the most detailed way, describe the nephrocalcinosis in children. And they show a range. There's a nice grading system of sort of 5 grades of nephrocalcinosis, 1 being the least, 5 being the most. And they had, I think, in the 20 or 25 patients they described, there were really no problems related to the nephrocalcinosis, except in one patient that had a slight elevation in a blood test that measures kidney function, the creatinine level. And when his therapy was decreased a little bit, that creatinine corrected. So at these higher levels of nephrocalcinosis, there may be something going on at the kidney level. That aspect does appear to be reversible based on that paper. But given the doses that we're using, and that paper also showed a correlation between the phosphate dose and the degree of nephrocalcinosis. So given what we see in our patient population with perhaps an effect of that slightly lower phosphate dose, we don't see really any of the severe nephrocalcinosis. We see it at a very low grade with some frequency. We rarely see it progress. And based on that, we've ended up not, at one time we were doing these ultrasounds annually because we were very concerned about it. It had just been described. But with the continued experience we've had, we've backed this off to every 2, 3, and now in some cases every 5 years of doing the scan because we're not seeing progression, and that might be a function of our common treatment regimens. Some of the perception about kidney calcification and renal function probably relates to an older generation of therapy, probably even prior to calcitriol, when people were treated in the 60s and 70s with extremely high doses of vitamin D. And as many of you know, this drug is not like calcitriol. It stays in the body, and by the time people figured out they were overtreated with this drug, you couldn't eliminate it from the body, and the calcium exposure could be quite high, and the excretion of mineral through the kidneys could go on for months, and there wasn't anything you can do about it. And subsequent to that kind of treatment and monitoring, there were people that developed progressive renal failure in association with renal damage. But in the days of calcitriol and the monitoring that we do now, we haven't really seen that as a significant issue. My bias again is the children, but I work closely with Carl and Sonia, and many of you know him, and that's been pretty much the case in the experience in the adult population he cares for. Be curious to hear Maggie's comments on that as well.
I usually work in concert with one of you to titrate their doses. I still don't clearly understand all the recommendations you make of changing or sometimes coming off of these drugs during adulthood. And so I don't modulate it. I do the arthritis side. But I do often wonder why patients feel better on therapy of vitamin D. Like why they seem to just move better. And I don't understand why it would make a difference in an adult, why they would sense it, I guess.
Do you mean on native vitamin D in addition to calcitriol and phosphate, or calcitriol?
Calcitriol, sorry.
Okay,
yeah.
Okay.
They seem actually to feel better on therapy through their joints.
Yeah.
And I don't get it, but I've been...
Well, we see it as critical to the therapy in children because of its ability to maximize a phosphate effect, yet give less phosphate, and it also is very important in keeping the PTH level down. If you gave unopposed phosphate to this group, they'd all have pretty raging hyperparathyroidism, right. And maybe it's a converse of a PTH effect. So
maybe it is.
And also just to add to that, in the untreated cartilage, the mineralized zone of articular cartilage is absent in the murine model. There's no mineralized zone at all. There's a lot of huge upregulation of proteoglycans, but no mineral. And when you treat the animals, that mineralized zone now becomes apparent. And so it is the consequence of treatment and normalizing phosphate levels, well, not normalizing them, but improving them, that improves the mineralized zone of the normal joint. The next question, are there any drugs that don't interact well with either phosphorus or calcitriol supplements? I'm not sure if this question was meant to address acute treatment, for example, with like tetracyclines or anything like that, or chronic treatment, or with drugs, or with any sort of over-the-counter supplements? Speechless?
I'm sort of running a list of drugs in my mind. I didn't see this one, actually. I printed everything out, and I was kind of ready for it, but I'm trying to going through the childhood drugs, and you know, the only thing that comes to mind right off the top of the bat is the co-administration of calcium and phosphorus. We tend not to want to give calcium together with phosphorus, and sometimes, you know, children with XLH are children regardless of the XLH, and so their calcium content of their diet is perhaps not optimal, and that's something that shouldn't be forgotten and something we harp on children without XLH about, but it's also part of the equation in children with XLH. So we do, given the full story there, people are actually pretty good with calcium in their diet, but occasionally we run into somebody who's not, and we have to consider adding calcium supplements. And so we try to space them so that they're not given within an hour or two of the phosphate supplements, because the two given together might prevent the absorption of one or the other. So that's one piece of the story. The other great misconception that continues to come back to me over and over again, not so much in XLH, but with other disorders that we see in which calcitriol is used, is that because of its name, some people think calcitriol is calcium or some form of calcium, and it's not. So we really have to, when we're talking to some of the patients that are on this for other reasons in particular, but it might occasionally come up in XLH, but have to, you know, make it clear that this is really a vitamin D metabolite, not calcium. So we don't tend to give it in concert with vitamin D, and yet there are times that we do, because you do want to keep the vitamin D levels normal too, because it doesn't entirely replace the vitamin D, but sometimes you have to kind of sort that issue out. I can't think of anything specifically. These are both pretty widely used drugs, and I can't think of anything other than those guidelines that I've commonly run into as concerns about giving either of them with another medicine.
Thank you. So there's a few questions in the mix coming up that I know will be specifically addressed by the second panel. So I am going to skip around a little bit, but I will progress to the next question. Blood pressure. Is high blood pressure common among XLH patients? What about the salt content of phosphorus supplements for a patient with elevated blood pressure on a low salt diet?
You know, I actually worry about this a lot, and I mean, some of you know that one of my harping things is to try to stop using the phosphosoda as soon as the children can swallow a potassium-containing preparation because of that sodium load. We haven't seen high blood pressures that much in kids, but it does. You know, and I can't tell you in reference to the normal population, but we do see a fair amount of hypertension in adults with XLH. And in one study that we did some years ago, and we haven't quite seen all the data yet from the recent cross-sectional study with respect to the heart ultrasound data, but there are large left ventricles in people with XLH. So this, what we call increased left ventricular mass, is probably a reflection of some degree of hypertension, because it happens over time, that ventricle, that chamber in the heart that has to push against all the pipes coming out of the heart, has to work a little harder, and the likelihood of that is this increased tension in those pipes, which is essentially the same thing as high blood pressure. It may not be the typical types of high blood pressure that are seen in the general population. One of the things we had done some years ago is also do stress tests on people, and what we found was that there seemed to be results that were most compatible with a kind of a stiffness of the blood vessels, that if you did the blood pressure at rest, you didn't see the difference, but if you put them on a treadmill and then looked at how the blood vessels are supposed to adapt to the increased blood flow of exercise, there wasn't the ability to do that. So it may be that it's there, but there have to be special conditions under which you take the blood pressure to see it. But all of these things have led us to be cautious about the sodium intake in the pure sodium phosphate preparations, which we tend not to use at all, except in the little babies who have to have a liquid preparation, and it's just so convenient to use the phosphosoda preparations that we feel we can get by with that for a few years, but subsequently want to get people on the potassium sodium mixes so that they don't have that sodium load. Again, it's theoretical, but there may be something to it given the limited information we have.
So that study that Tom referred to was something that I became interested in the left ventricular hypertrophy. Was there any sort of calcification of the vasculature? And the projection here would be that we wouldn't have intimal calcification, but we would have calcification of the sort of the interlying tissues. And so those studies were not funded. There are lots of studies in XLH that have not been funded. So part of our advocacy for the XLH network really is to get behind and keep harping to the NIH that we really do need funding to better address a lot of these questions that are just have not been addressed. So that's very important. I do believe that Dr. Mohammadi at Harvard may be pursuing some of these studies on the vascular calcifications associated, the possible vascular calcifications associated with XLH. So you can keep an eye out for his work. The next question we'll progress to, this has been touched upon several times within the session, but if you want to maybe contribute something a little more specific, you're certainly welcome to. So topics that have come up recently with widely varying experience. Is there a normal range of phosphorus supplements and calcitriol supplements for children, teens, and adults? How is it calculated? Any amounts below the treatment is worthless or above, which is potentially dangerous, even with blood level monitoring. So this is effectively about management of the disease. Any additional comments? Tom, I'm so glad you came today.
Yeah, so it is a wide range of doses we use, and we get to that dose in a trial and error form on every patient, and it's based on starting at kind of a general range, within a generally accepted range, and it is modulated on the basis of what the response to the blood and urine tests are that we do, and then also modulated by efficacy parameters. And sometimes the blood tests aren't telling you how well you're doing. You have to, that's why we're so, manic about getting the right growth plot data down, see how the growth is going, look at the degree of bowing, do those x-rays at certain intervals to make sure the epiphyses are staying okay. And so our overall approach is to try to use these things to come up with a dose that isn't going to be excessive for that patient, but is going to be effective. And so because of the wide variety and wide spectrum of disease that we encounter, that dose ends up perhaps slightly differently on many, many kids. But that being said, when you go back and look at the ranges that we use and compare it to people around that are doing the same things we are, we tend to fall into a range, and there's an occasional outlier for the reasons that we've discussed, because we got there a little differently than we do most people, but it's usually between about 20 and 50 or 60 milligrams of elemental phosphorus per day per kilogram body weight. And so that's kind of where we are. Many of our patients are on probably at the max about 6 tablets of Nutrifos or K-Phos neutral a day, and we have many on less. We adjust downward a lot when we see the PTH going up, and we use as efficacy parameters primarily growth and what we see in terms of bone disease on the x-rays. The serum phosphorus level, and this is a composite question, and one of the ones I read in the packet was sort of asking a similar thing in terms of the blood monitoring issue. And the serum phosphorus level in the past has been something that people would say when it's at a low level, you need to give more phosphorus. And this is something we've really taken kind of a strong stance against, because that kind of approach has actually led to giving excessive phosphorus, which has in turn led to the uncontrollable hyperparathyroidism that we've seen. And the physiology is kind of, when you really think about it, the basic defect here is at that kidney ability to pull back phosphate into the system. And you don't cure that by giving phosphorus. You try to overcome the losses. You don't cure that basic defect. So the more phosphorus we give, actually the more goes out in the urine. But if enough stays, there's enough to mineralize the bone. And what happens when you measure a blood phosphorus is that it's picking up that blood level at some, given most clinics, some random point in time. And particularly if a patient hasn't taken a dose of phosphorus in a long time, that serum phosphorus level is not going to reflect at all what the body's seeing most of the time or what the phosphate load is. It's still going to be in the range that people have with generally untreated XLH. If you had a clinic operating the way we sometimes do our research studies and measure the blood phosphate frequently through the day, you could maybe do better at doing that, but that's totally impractical thing to do. So the blood phosphorus level sometimes can get up and stay high more so in a toxic setting, but its use as a marker of efficacy is not good, and that's why we sort of seek other ways to get there. Sort of getting off on the monitoring issue, but so that, at least in childhood, that range of dosing tends to be between about 20 and 60 milligrams per kilogram body weight per day.
Thank you. I'm going to jump. So in the spirit of time, I mean, we did accommodate a little bit of extra time so that we could go over a bit. So we'll just try to get in a couple of more questions. There were a couple of specific ones that we did want to address about dental implants.
So the question is there anything we should tell the oral surgeon or any risk we need to know about? So as I just learned, blood pressure can be a very important consideration. One thing is that any procedure, when you're going to oral surgeon, it is like a mini surgery. So you have to get the whole team involved. It has to be your primary care physician or pediatrician, endocrinologist, and whoever is managing the disease for you. That's one. And then the consultations have to go back and forth so that optimal results can be achieved. What bleeding with the high blood pressure, too much bleeding can be a very important consideration. Delayed healing hasn't been mentioned much in the literature with XLH, but intuitively it would make sense that there might be some delayed healing with implant or any kind of extraction in case of patient with XLH. I feel there is a lot of research that is needed as far as dental implants and oral surgery and XLH is concerned. And one of the questions had asked if there are any supplements that can be given. So the implant depends upon the available calcium and phosphorus to bind. So there can be some supplementation. However, there are no guidelines on it. So I would like to ask Dr. Carpenter that if somebody has to go for any orthopedic surgery, do you give them supplements?
Well, in the childhood population, it's because they're on treatment, we pretty much stick with it. In the days when people were really kept immobilized for some period of time after the surgery, we went to a half dose for a few days after the surgery was completed so that there'd be some limited risk of hypercalcemia. But we still do that historically. I'm not sure how necessary it is, but after a few days, within a week, get back up to the standard doses. In adults, I think it's a more important issue because so many of the adult population is not under standard therapy, and colleagues that I work with would recommend treating for some period of time before surgery. And I don't want to put words in their mouths, but it's delineated in the publication that Carolyn referred to in the JBMR, where we actually address that issue. But for several months prior to therapy and for after therapy, adults going for orthopedic intervention, it's suggested that they go on at moderate, low to moderate doses because it does is likely to make a difference in the healing of the intervention.
Thank you. And then there's a question that says how successful the implants are. So the implant failure is dependent on a lot of things. It can high failure is in smoking and diabetes. So if you have XLH and you either smoke or have diabetes too, it would lead to higher failure. There is no real data as in XLH because as I said, there are 4 or 5 articles that have shown interest in this. But what it did say that if there is a group that has a high failure rate, if they're given some antibiotics perioperatively, that is when the surgery is about to happen, if they are given some antibiotics like penicillin, if you're not allergic, if you're allergic to penicillin, something else, it does decrease the failure rate significantly. So that is another consideration, especially if you have a delayed healing. Does anyone have any more questions? Yes, please.
Did the use of site preservation material following extraction, would that benefit the success rate?
Yes, site preservation, it is. The only thing is that infection is a significant consideration for why the extraction was done or why, what was the problem with the tooth to begin with. Then you'll have to discuss in detail with your provider that if that site preservation with any grafting material is a choice. Now there are local drug delivery systems where you can put the drug around the area so you don't have to take it by mouth. But then as you had mentioned, it comes down to a lot of financial considerations too. So most of the most viable choice is the perioperative antibiotic intake.
Is there a relationship or a frequency to TMJ in XLH patients versus just maybe arthritis in the jaw?
Okay, so I can say I'm a pediatric dentist, so no. In children, it has not been specifically mentioned. There are very few conditions where actually TMJ is involved, specifically in children. And based on my research that I did with Dr. Carpenter, I think we saw about 30 adults and 22 children, and we did not find any TMJ issues. And the literature doesn't mention TMJ as a major issue either. Yes, please.
A related question. My dentist was at the dental convention in San Francisco, and someone asked if there were any orthodontists in the group, and did they have experience with XLH? I don't know.
So, in children with XLH, sometimes the canines, the eye teeth, they can come in a different position, like it's called ectopic eruption. So they need orthodontic treatment, but orthodontic treatment has been documented to be very successful in XLH patients without any complications.
Okay, I think we have time for 2 short questions. I'll take liberty of choosing them because I think I've heard these before, and maybe even Dr. Sharkey might weigh in on this too. What is the latest recommendations for XLH children on growth hormones?
I think I have to defer to Dr. Carpenter. I personally haven't seen any XLH children on growth hormone.
Yeah, this is something that has been used with some variability in different centers around the country. It's not a specific therapy for XLH. Growth hormone's been applied in a number of settings now to try to enhance growth. And the concern that has come up in some of the anecdotal reports have been that because this disease at the cartilage level is a growth plate disorder and growth hormone is working at the growth plate too, it's working at a point before where the molecular problem is in terms of the growth plate defect. And it's thought that it probably isn't going to have the same effect on the long bone, which is where you get your growth from, that it would in say, a population that didn't have XLH. And yet it might work at other sites, in particular the spine. So one of the things that happens in XLH is that the spine tends to grow without treatment more close to the normal rate than the long bones because of the growth plate of the defect being so much more predominant in the growth plate of the legs, in the femur and tibia. So that the application of growth hormone might actually make the relative growth of the spine greater than the long bones. And if that happens, you exaggerate the disproportion that happens, and although you might get some effect at the spine, some effect at the legs, the effect at the spine might be greater. So you might get a little bit of growth, but most of that growth coming from the spine would create that increased imbalance between the truncal size and the lower leg size. So we've kind of shied away from it because of those concerns, and other things I've seen posted with more than just a few times is a consideration that there might be bone age changes with the use of growth hormone. So it's kind of an area in which there's a lot of uncertainty, but the gain seems to be limited, and the risks seem to be maybe even a little bit more than limited. So we haven't gone that route with most of our patients. The place where we have reserved the possibility of the use of growth hormone in XLH is if people also have a concomitant deficiency of growth hormone, and we actually occasionally test for that in some of the patients, but we haven't really seen it. The other things that have happened with growth hormone over the years, there's been a number of studies, and some of them go one way, some of them go the other. The most recent study tried to look at the disproportion issue, and they really didn't see the disproportion that we had sort of thought you might see. And in some other studies, the rickets got worse with the use of growth hormone. So it's a bit of a mixed bag, and I'm not sure that it's a great downside, but I'm not sure that there's a great gain from it. And at the same time, it's extremely expensive. And so, you know, we haven't taken anybody off of it that's come to us on it that have been started elsewhere, but we haven't been convinced that it's been a great therapy.
Thank you. So we're going to do one last question. Much of the remaining questions really are going to be addressed at some level in the second panel, so I don't think we're missing a lot. And I do want to encourage you, for those of you who can stay with us for lunch, to please, you know, feel free to approach our panelists. So the last question for panel 1 is question 30. I have had several large degenerative subchondral cysts in the femur and the tibia. Are these two a known complication of XLH or just osteoarthritis in general? I have had some of these burred down to bleeding bone during arthroscopic meniscus repair in 2001. There are large hypertrophic spurs in my hips with flattening of the superior aspect of both femoral heads. Common in XLH?
I'll speak a little bit to this. So, one aspect of degenerative arthritis are subchondral cysts. That's a marker of degenerative arthritis or breakdown of cartilage and underlying bone at the joint in general when you have arthritis. You know, is there a different aspect to the degenerative changes in XLH rather than typical osteoarthritis? I would say probably. But subchondral cysts and bone spurs at the joint level are typical of arthritis. And flattening of the femoral heads, also an aspect of typical degenerative arthritis.
And as best as I can tell from the literature, this does not appear to be a rheumatoid arthritis, but instead a true degenerative arthritis. And in support of that really are these structural changes that we do see in the cartilages of XLH. You absolutely can.
I think I have one of these. Dr. Sharkey's going to relax because she's going to see something that she works with every day, which is a joint and a bone. Okay. So I'm going to show you a picture of a joint and the bone spurs. But when you have a normal joint, I really want to remind you when you're talking about pain, and I saw questions about gelling and about moving and functional changes, that a joint isn't simple, right? That some people's pain will come from the lining of the joint in an inflammatory disease, and some will be the ligaments and insertions as they're trying to support bone, and some will be the cartilage as it frays, and some will be the softening of bone beneath, which leads to these changes. So when people stand outside of you like me, who's learning with you about this disease, I can tell you it's not simple where the problem's occurring, and we try and align it so that all these things, I think they'll talk about this afternoon, all of these things can work together to make you more functional and with less pain. So that was just a picture of where pain comes from. When you look at a joint with degenerative disease, so this is a finger joint, and this is the bone, and this is my finger, and this is the cartilage, and this is where the cushion comes when you put weight across a joint. Then in a degenerative joint, I think you can appreciate that you not only wear the cartilage, which Carolyn was speaking about and Dr. Sharkey, but you get this big osteophyte in a response to bearing the the weight. And in XLH, so this is normal bone here. This is a normal hip joint here. And everybody gets a little arthritis with aging, but with XLH, you get this little extra tufting at the insertion of muscles and around the joint. So the subchondrosis, as Dr. Sharkey said, reflect the stresses going through, and that's kind of the end stage I would see in anybody with osteoarthritis. And when you all get up with us to go to lunch, and you're like this, that's gelling, and that's also true of anybody with osteoarthritis. And I tried to look it up for this conference where the word gelling came from. I thought, gelatin? Why would a doctor talk about gelatin and gelling of a joint? In the 1946 medical dictionary I could find, there was no gelling. So gelling's evolved from probably Dr. Sharkey in my field to describe the cartilage kind of getting back into motion. And it's a transient phenomenon of being quiet. I don't know if you understand better what happens at the tissue level, of being sitting here for 2 hours and then trying to get up and get everything moving again. And as I say to all my patients over 50, you make an appointment to get out of bed. So that I think happens a little earlier in your disease, but that passes and is not by itself a worry. It is transient. Silence. That's all. I just had these pictures that made your comment fit. Anatomical.
Well, I wanted to extend a heartfelt thank you to our panelists today. You guys were fabulous. We had a great audience, but please.